new concepts are differentiation of myocardial infarction from myocardial injury, highlighting periprocedural myocardial injury after cardiac and non-cardiac procedures as discrete from myocardial infarction, consideration of electrical remodeling in assessing repolarization abnormalities with tachyarrhythmia, pacing and rate-related conduction disturbances, and use of cardiac MRI to define etiology of myocardial injury and CT coronary angiogram in suspected MI. The universal definition of acute MI is nothing but acute myocardial injury with clinical evidence of acute myocardial ischemia plus detection of rise or fall of cardiac troponin values at least one value above the 99th percentile and at least one of the following: new ischemic ECG changes, development of pathological Q waves, imaging a new loss of viable myocardium, and identification of a coronary thrombus by angiogram. Exception for type 2 and type 3 MI. The first WHO definition was primarily a ECG-based definition for epidemiological purpose. Then in 2000, EAC and ACC redefinition for biochemical and clinical approach, and it is for myocardial injury detected by abnormal biomarkers labeled as MI. Then the first universal definition in 2007, it is a novel MI classification system with 5 subcategories. Then the third universal definition, 2012, says more sensitive assays for markers of myocardial injury, particularly for patients who undergo coronary procedures or cardiac surgery. Then in 2018, fourth universal definition goes for adheres to the clinical approach. It differentiates non-ischemic myocardial injury from myocardial infarction. So this is the timeline, that is the definitions of MI. Before 1990, it was for epidemiological approach. Then after 2000, it is for clinical approach. Then the universal definition for clinical myocardial infarction is presence of acute myocardial injury detected by abnormal cardiac biomarkers in the setting of evidence of acute MI, that is acute myocardial ischemia. Then for myocardial injury is nothing but elevated cardiac troponin that is more than 99th percentile. Upper reference limit is defined as myocardial injury. Then cardiac procedural myocardial injury is increase of cardiac troponin values and rise of cardiac troponin values more than 20% of the baseline. This is a conceptual illustration of troponin kinetics after acute myocardial injury and infarction. The cardiac troponin as the time from the onset of symptoms. For example, in acute MI, in later sampling, the cardiac troponin values are more than 99th percentile. Delta may not be seen over a short period. So this is a spectrum of myocardial injury ranging from no injury to myocardial infarction. That is, the clinical evidence of acute ischemic myocardial injury is equal to myocardial infarction when it is associated with heart failure, tachyarrhythmias, anemia, hypoxemia, hypotension, shock, and kidney disease. So this is myocardial injury. It's a separate entity, though a prerequisite for MI. So the reasons for elevation of cardiac troponin values are myocardial injury that is related to acute myocardial ischemia, that is atherosclerotic plaque disruption, then injury related to acute myocardial ischemia because of oxygen supply demand imbalance, and the cardiac conditions, that is heart failure, myocarditis, cardiomyopathy, and so on, and the systemic conditions like sepsis, infectious diseases, and chronic kidney disease. The clinical criteria for MI is presence of acute myocardial injury detected by biomarkers in abnormality in the setting of evidence of acute myocardial ischemia. If you see a elevated cardiac troponin values that is more than 99th percentile, if there is a troponin rise with acute ischemia, it is acute MI. If it is without acute ischemia, it is acute myocardial injury. If the troponin level is stable, it is chronic myocardial injury. The types of myocardial infarction: type 1, it is due to atherothrombotic coronary artery disease. Then type 2 is nothing but oxygen supply demand mismatch due to atherosclerosis, non-atherosclerotic coronary artery dissection, and mismatch alone. Then The type 1 MI is nothing but detection of rise and fall of cardiac troponin. If it is associated with symptoms of acute myocardial ischemia, new ischemic ECG changes, development of pathological Q waves, and imaging evidence. This is type 1, that is plaque rupture or erosion with occlusive thrombus, or plaque rupture or erosion with non-occlusive thrombus. The criteria for type 2 is because the value of one value above the 99th percentile, and if it is associated with myocardial oxygen supply demand imbalance, and if it is associated with symptoms, new ischemic ECG changes, and development of pathological Q wave. This is a type 2 due to atherosclerosis, vasospasm, and non-atherosclerotic coronary dissection and oxygen supply demand imbalance alone. So then the type 3 is nothing but a sudden cardiac death in patients with myocardial ischemia before the cardiac troponin values become available. Then the coronary procedure-related myocardial injury, the 32% of patients undergoing PCI or CABG procedural myocardial injury as calculated by cardiac magnetic resonance. A large proportion of patients have abnormal values of cardiac troponin after PCI, ranging from 20 to 40% in stable coronary artery disease to 40 to 50% in MI. So the criteria for PCI-related MI is the elevation of cardiac troponin with new ischemic ECG changes, new pathological Q waves or imaging evidence, or the angiographic finding like dissection, occlusion, disruption, or embolization. So this is the temporal, that is a scaffold thrombosis type 4B, acute, subacute, late, and very late. Then the restenosis associated with BCI is type 4C, it is instant restenosis. Then if it is associated with CABG, it is classified as a type 5. So 32 to 44% of CABG patients have myocardial injury, and it will be the 10 times the cardiac troponin values will be elevated as against 5 times in patients with PCI. So this is then MINOCA, the MI in no angiographic obstetric coronary artery disease. It is present in 6 to 8%, more common in women, and it's classified as type 1 and type 2. So this is a diagnostic workup chart. Then unrecognized MI, pathological Q waves, imaging evidence of loss of myocardium, and pathological finding of prior MI. Then this is a new terminology, occlusive myocardial infarction. The OMI is defined conceptually as acute coronary occlusion or near occlusion with insufficient collateral circulation such that downstream myocardium will undergo imminent infarction without timely reperfusion. The ECG findings are given in the stable hyperactive T waves, pathological Q waves, any ST elevation in inferior leads, so on. So here are the 10 commandments for the fourth universal definition of myocardial MI. 1. Myocardial injury is defined by presence of cardiac troponin values above the 99th percentile. 2. Myocardial injury may be acute if it is associated with acute heart failure, or chronic if it is associated with chronic kidney disease. 3. Myocardial injury may occur in a variety of situations, including after coronary intervention, with or without cardiovascular and non-cardiovascular illness. 4. Occurrence of acute myocardial injury in the setting of acute myocardial ischemia defines acute myocardial infarction. 5. The type 1 is acute atherothrombotic coronary artery disease. Type 2 is due to imbalance between supply and demand. Type 3, a sudden cardiac arrest before the enzymes become available. Type 4A, due to the cardiac troponin more than 5 times, and if it is elevated from the baseline. Type 4B is acute myocardial ischemia injury related to stent thrombosis. Type 4C, if it is associated with restenosis. Type 5 is nothing but associated with CABG. The cardiac troponin levels are more than 10 times the 99th percentile from the normal, or if elevated, stable pre-procedural baseline. Thank you for nice listening.